Great. Thank you very much for joining us today. Welcome to part 2 of our webinar series, Putting Digital Health into Practice. I am Renee Kwashi, the Vice President for Digital Health at the Consumer Technology Association, or CTA, which is a large trade association representing the tech industry, probably best known for being the owner and host of CES, which we hold every year in January in Las Vegas. CTA has a large health division, and some of our panelists are actually board members of that division. And that division's mission is to increase the use of technology-enabled value-based healthcare to help reduce healthcare costs and drive better outcomes. We're proud to be partnering Digital Medicine Society, or DiMe, on important discussions at the intersection of health and technology. DiMe is a global nonprofit whose mission is to achieve the safe, effective, equitable, and ethical use of digital medicine to optimize human health. So a lot of synergies between CTA and DiMe, and in fact, we've collaborated on a number of fronts and on a number of initiatives. Last week in part 1 of the series, we had a great panel discussing bias issues implicated by the use of AI in healthcare. It was a very fulsome, open discussion with a diverse set of perspectives, and we're hoping to do the same today. So today, we're going to be discussing technology stakeholders and the opportunities and challenges they're facing as they navigate the complex U.S. healthcare system, as well as issues faced by healthcare stakeholders fully integrating tech into their systems. And we have a great panel to tackle the issues from a variety of perspectives. Before I get to that, a few housekeeping items that I want to convey to you. Next slide, please. Today's session is being recorded. That's number 1. Ask a question. You have 2 options, but we really want to drive you to the Q&A portion of the platform. So if you have a question, just type into the Q&A box and we'll get to your question as appropriate. And today's recording will be available after today's session. Next slide. So with that introduction, I'm going to turn it over to our wonderful moderator, Schiller, and he's going to get us going. Drew.
Awesome. Thanks so much, Renee. And on that last slide, it says the Chief Medical Officer. I am not a doctor. I do play one on TV and on Zoom sometimes, but I'm the Chief Executive Officer of Validic. Very happy to be here today. I'm also the chair of the CTA Health Division that Renee was just mentioning, and I'm on the CTA Executive Board. Really appreciate the opportunity to chat today with some great panelists. I'm going to have you all introduce yourselves in just a moment. And I think that what is most exciting to me about this conversation is somewhat of a tongue-in-cheek, but also a very real question, which is, how's your digital transformation going? And I know for various organizations, there are things that are going well and there are things that they're very challenging, and we hope to head directly into that today. So the first thing I'm going to do, maybe Jen, we'll start with you, is first introduce yourself and answer the question, what are you working on today in February 2022 that you were not focused on in February 2020? So I'm going to have each of you do that, and we'll start with you, Jen.
Fantastic. Thanks, Drew. Hi, everyone. My name is Jen Goldsack. I'm the CEO here at the Digital Medicine Society, or DiMe. Renee did a fantastic job of introducing our organization, so I'll dive straight into our question. Drew, it's a great sort of icebreaker, if you like. What are we doing now that we weren't doing a year ago? We're thinking about scale, and I think that's the difference. A year ago, even in the midst of the pandemic, we were still thinking about a point solution here, a small change there. And what we've really seen is this question of not, is digital transformation coming and how are we going to handle it? But digital transformation is not only coming, it's here. And how do we think about success at scale? And success defined by access to care, by equity, by efficiency, which includes cost, but isn't necessarily driven by cost. One of the frustrating things to me in the telehealth debate, for example, is this idea of overutilization. Maybe people have just been getting the care they need. And then, of course, we want to be effective, right? Not just validation of a solution, but actual clinical utility in what we're doing. Are we improving people's lives? Are we trying to unburden our clinical colleague? And as I said, the real difference between last year and this year is that we're asking these questions at scale, Drew.
That's great. Thanks so much. Han, how about you?
Yeah, hi. I would say really the focus on the home as the next frontier of medicine. Um, I think it's very clear that there's been a shift from healthcare in the hospital into the ambulatory care center, and there's a shift towards more efficient, lower care settings in which that is largely being pushed through or because of the cost pressures. But I think the next generation or the next wave of that is beginning to happen in the home. The challenge that we see and the reason we're focused on it is we see the digital transformation causing unintended consequences. So we have great innovations in the digital health world, but yet these are all one-off or silos because the current market doesn't allow scale in the way free market would allow because of the incentives that are not aligned or structural issues and all the things that we already know about. And I think that the challenge now is not about how do you connect the pieces in the home, but how do you do it with truly patient in the centered and create a unified, cohesive view, both as a consumer and a patient in one, and the caregiver being part of that equation. So I think the home is the next warfront, but yet it is a very complex and different set of challenges. So that's kind of what we're excited about, but also the challenge we're working on.
Thank you. And Han is the Chief Medical Officer of Samsung. And Aaron, same question to you. What are you working on? Introduce yourself, and what are you working on today that you weren't working on pre-pandemic 2 years ago?
Yeah, I'm Aaron Martin. I'm the Chief Digital Officer for Providence. We're a large health system based in the West Coast. And the big thing that's just been a huge economic issue for us is the workforce crisis. There's no hyperbole I can come up with that can express how economically damaging that is to our health system in particular and to other health systems as well. And the work that my team is doing is how does digital kind of help to address that, right? And so these three kind of concepts are pretty kind of interrelated. The first one is how do you basically deliver safe self-service to the patient to offload a lot of the work that we pay caregivers for today and that the patients actually want to do. And so we've talked about this in the past about, how do you make sure that every service that we provide has a digital endpoint? So first thing is self-scheduling, for instance, telehealth, asynchronous care, and an API. Those are the four components that we've always got to have for all that. If you look at primary care and urgent care and retail health and those types of kind of services, I think we're kind of 80 to 90% down on the journey as from Providence standpoint. If you expand it to literally everything like specialty, the ability to schedule with radiology and imaging, all that fun stuff, we're probably still in the kind of, I would say, 30 to 40% in terms of endpoints, but again, probably 60% in terms of volume, like the number of, what patients interact with. And that was the reason why we chose that. Second thing is burnout for our clinicians. They're getting absolutely creamed with messages right now. So, so good news is patients can message with patients can message with physicians. Bad news is patients can message with physicians, and physicians are, taking 2 to 3 hours of the already precious access time away from that. And the way healthcare approaches that problem is not surprising. They go through workflows and that kind of thing. How technologists think about it, especially if you come from an Amazon perspective, is every message a patient sends to you is a defect, right? So that's how we thought about it from a consumer standpoint. So when you contact Amazon, that means we did something wrong. We confused you. We didn't have a technique for you to do self-service and those types of things. And what we found is with those messages, we think 30 to 40% of them don't have to exist. Patients, we just haven't provided the right content and the right tools for them to do it themselves, that kind of thing. So 2 examples. Third example of what we're working on is looking at new ways of new workforce models. Healthcare has got the most backwards way of working, and this is saying something. Backwards way of working with our very precious and limited supply of nurses, for instance, or pretty much anybody, but like it's the absolute opposite of a gig economy type of flexibility. And the demographic makes it even worse because 70% of our nurses are female. They have, all kinds of other stuff going on at home. And then we're asking them to kind of sign up for 12-hour shifts, over a 3-week period or whatever, and it's just insane. And so what they're doing is they're doing the rational thing. They're going into agency and saying, I'm going to choose that shift and that shift and that shift. So they're creating their own kind of a gig economy. Problem for us is that that causes us to pay 30 to 40% more, for the same individual doing the same work. So lots going on with us.
Wow, that's fascinating. I'm really looking forward to digging into more of that in this session. Thanks for that, Aaron. And Dave, please introduce yourself.
Thanks, Drew. A real pleasure to be here. My name is David Rhew. I am the Global Chief Medical Officer for Microsoft. During the pandemic, we've seen a transformation that we haven't seen before around digital, about 2 years worth of digital transformation in 2 months, significant uptake in telehealth and remote patient monitoring. But what it also has done, it's given us an opportunity to start thinking about how we can transform clinical practice to address some of those key issues. Aaron highlighted one of those around clinician burnout, finding ways that we can remove administrative tasks such as entering information into an electronic health record by using voice AI. But it's also taught us that we live in an interconnected world, and largely what we have viewed as the health system and the patients that we control and that we manage or we should support, I should say, in the process. That's really just a small part of how we address all of health. A lot of health has to do with what happens not just within our own neighborhoods, but outside of our neighborhoods, what happens outside of our country. And in doing that, sort of reflection of what can we do to help address that, we've been leaning in to try to support efforts around helping the World Health Organization build out their single data platform, establishing the data lake, the data directories, the country portals, the ability for us to build workstations on that, looking at ways that we can expand some of these services to underserved areas, the vulnerable individuals, those that oftentimes don't have priority, perhaps maybe not even the capabilities to be able to access healthcare, leveraging public-private partnerships to be able to deliver on that. And then also empowering consumers to be able to take advantage of their own health records by pulling that information onto either digital or perhaps paper formats using smart health cards. So these are all the areas that we've been looking at. Sort of there's been the digital transformation, which is just accelerated, but also thinking outside of what we traditionally view as healthcare.
Yeah, that's great. Thank you so much. And it's super exciting to hear, especially the work with the WHO and the underserved populations. It's really great. And, I think that is definitely a big shift over the last 2 years, right? Is even the fact that the WHO is thinking about a global data platform like this, I think is super exciting. That's really helpful. And just to tie this off from my perspective, Validic plays in the remote care space. We bring data in from any sort of consumer health or in-home monitoring device into the clinical workflow to drive remote care at scale. And the scale is the key. And Jen, back to your point, I'm going to kick this over to you for our first big question. But the scale piece is what we're actually mostly helping our clients through today. That wasn't something that was really up for conversation as much 2 years ago. And so, as you're thinking through that, Jen, I'm just curious, what are some of the challenges that healthcare faces as they're looking to scale digital transformation as you see it?
Thanks, Drew. And it's a great and really important question. There's a phrase that I use often with my team. I probably drive them crazy, and also our partners, which is, if you don't know where you're going, anywhere will get you there. And I think the biggest challenge we have in healthcare right now is, what the hell are we doing with digitization, right? What's our goal? And I think what we've done previously, and it's great having partners like CTA, because we can see how dominant digital has been in all other industry for decades now. Previously, as we've tried to introduce it into healthcare, we've been trying to protect existing workflows that we know aren't working either for the providers, and Aaron gave really nice voice to that, especially now after a day of seeing patients and then a day of charting, you're now sort of servicing the portal. Now we want you to look at a dashboard as well. Like, that's not going to work. Existing payment models don't work. We know these things. So what are we doing with digital? Are we going to try and use that to nibble around the edges and try and shore up a system that we know is broken? I think the greatest challenge is actually being bold enough to step back and collectively say we need to do something differently. And it's happening. And we had this sort of conversation in our prep call. We only need to look at the Walmarts, the Amazons, the Best Buys, the CVSs. You know, they're moving. 1 in 2 Americans walks into a Walmart every single day. If they can start to get their healthcare there, if they can get it as easily as they can do Amazon one click, you can be sure as hell that they're going to do it. So this is not something of the future, it's happening. We have to collectively get comfortable with this idea that healthcare as we know it is changing. And it's clinically appropriate too, right? No one's saying that highly complex patients should be kept out of the hospital, but we need to redefine really good healthcare as being healthcare that moves outside of the clinic, that's built around the patient, that good healthcare is when we stop people from getting sick in the first place or needing to come to the clinic, not how good are we at a patch-up job once they present themselves, right? And the disease burden that we face in the US in particular, the vast majority of it in terms of incidence and cost isn't well suited for our high acuity care system, right? We know that chronic disease isn't solved in a 15-minute clinic visit that you had to pay for parking for once a quarter. We know that mental health needs aren't 9 to 5, 5 days a week. These are things that we know. And so I think the biggest challenge, Drew, and I'm really proud of all of our partners here, you know, I know that you've been driving at this for Validic for a while too now, is what is our North Star? What are we doing here? What does digital innovation in healthcare even mean?
Yeah, thanks for that, Jen. And, you know, just to echo something you said in your introduction, you said we talk about overutilization, and maybe people are actually just getting the care that they need. And I thought that was a super interesting point that I want to dig in a little bit more. But others, just curious, Han, Dave, Aaron, any thoughts on this topic of sort of what are some of the foundational challenges that healthcare faces as looking to scale digitally?
I think it's hard to take shortcuts. If you look at how other industries evolve, they evolve faster, but you have to get the basic, transactions and engagement. If you look at how e-commerce works, right? So if you look at like how Amazon evolved, they started off with, getting the transaction right. Then they moved it to engagement, which is Prime, right? And I think you have to kind of go through those steps before you can get into more kind of, once you do that, the way I've kind of explained it to folks is, at least from my perspective, is you then earn the right to do more fancy things digitally in a healthcare context, right? I think to Jen's point, all that won't matter. We will still say in a very, very robust fee-for-service environment if you also don't put risk into the equation. That's the other side of it that is kind of not necessarily related to what happens with digital. So for instance, you could digitize our existing, health system, make it somewhat more efficient, but it's not under risk. And so you're not going to really have true kind of changes in utilization management. It'll just be a super efficient way of delivering fee-for-service care, right? So that's my worry is if you, and the two really aren't that related, right? One is more of like a policy kind of economic business model thing. The other is a technical problem, right? Or an consumer adoption problem.
Yeah, I think Jen brings up a really good point, and that is that we oftentimes try to put a Band-Aid on a large wound and assume that we're going to solve the issue here. By simply providing easier access or for making things more user-friendly, that will help. But when you think about the most complicated patients, the individuals with the greatest number of comorbidities, the number of people that are coming in and utilizing the highest amount of resources, the highest cost, these are individuals that oftentimes have more than just simply their healthcare. They're dealing with social issues, and it's difficult for individuals that don't have stable housing, that don't have the adequate food, that live in neighborhoods that this is not a top priority. Their number one priority is to keep their children safe and to be able to earn a living. That is the difficult challenge that we have. And when we think of healthcare trying to solve those challenges, we are taking a very narrow look at what the issues are. I know that many organizations are trying to figure out ways to address social determinants, but it really goes well beyond what a healthcare organization can do or an individual practitioner. We need to start rethinking about how do we leverage public-private partnerships, individuals and organizations that work already in the communities that support these individuals, identify the risks, solve for them, build infrastructure, create support. I mean, that's the way that we're going to be able to get out of some of the hardest challenges that we have. Everything else that we can do, we can try to make things better, and we will make things better with digital. But if we want to hit the big problems, we're going to have to start thinking about how we engage more people and more organizations around this common goal of helping societies and communities get better health.
And the one thing I would just add to what David and Jen spoke about on scale is really, I think there's a lack of this is a workforce and a technology issue and a business model issue, in that I don't think there is really a Sherpa or a structural workforce that really advocates for the patient in the whole. So if you're a hospital, you have a certain view of the patient, but it's still a slice of the patient. If you're a payer, you have a certain view of the patient from a population perspective, lowering costs, right? And then you have digital innovation companies that are trying to take slice of that. Right now, I don't see any coherent either workforce or an architecture in which someone is really more formally taking care of the patient. So there's one door, one digital front door, in which that becomes the navigation to various things that they need. And to David's point about social determinants of health and all that, there are these variables. And I just feel like we're still looking at it from the lens of how we're currently in the business. So if Samsung looks at a consumer, right? Everyone looks at the hospital. I think the challenge is that no one's really looking out for the patient or the consumer as a whole. And I feel like that's a missing ingredient.
Oh, and I really like that. And I think that goes back to Aaron's points about the necessary incentives to do this, right? If we want to think differently about that, if we're interested in even listening to who's advocating for the whole patient, and I feel for our patient advocate colleagues, I feel like they've been screaming into the wind for decades and no one's listened, right? We have to give them the incentives to do so. To David's point, you know, what you were saying about how we have to think more holistically, I do think it's really important. And I think digital can be a really powerful tool in recognizing that good healthcare has two components, right? There's clinical components and then there's non-clinical components. And I thought you gave those really good voice. And I think that some of the work that we've done with our partners at VA, for example, because they can be more holistic, we've actually started to see some upstream investments that they made even several years ago really starting to pay dividends, paying through the pandemic, but now in hardcore tangible outcomes. And Aaron, they have different incentives, right? They don't just have the ability to look at the different pieces, to be thinking about homelessness, to be thinking about their benefits, but they have the incentive. They are responsible for the life of a warfighter from the moment they retire all the way through to sort of end of life. And so they have those incentives. They think more holistically, and it's going really well for them. And David, I think the other piece is, and this reflects our strategy at DiMe to be sort of working with VA and then perhaps some of the more disruptive players. I do think, as you said, you know, when healthcare isn't your priority, but you are going to sort of Walmart, right? And you could potentially get healthcare there and it's safe and it's somewhere that you're going anyway, right? We have to meet the patients we're trying to serve where they are. So I think this is a tremendous discussion. And Aaron, really curious to hear how you guys in a more traditional healthcare system are sort of negotiating this, but my suspicion is that Drew's going to take us there anyway.
You could not have teed that up for me better. That's exactly what I was thinking is, you know, what I'm hearing is, you know, at the outset is digital can help, but digital's not the only thing. We need to actually flip healthcare fundamentally. And I'm curious, you know, Aaron, I mean, you are in a traditional healthcare system, thinking about this a lot, facing a lot of disruption from, you know, big tech as well as startups that are well funded that can sort of take a more targeted approach and be a lot more nimble. And I'm just curious, you know, how are you thinking about that, about trying to maybe prevent the disruption or be the disruptor yourselves, opposed to being disrupted by an external party?
Yeah, I would put it, so somebody once asked me, and they thought they were being clever. They like, which would you choose for your health system? A glorious digital platform that does everything, anything you want, or being under full capitated risk at a reasonable level? And I surprised him. I said, risk, right? Because like that is actually better for healthcare than, the model matters way more than kind of the tools and devices, et cetera, et cetera. And as a matter of fact, it begets the other, right? So it enables your ability to kind of do, better and more fancy things. And so to that end, what health systems are going to face three big challenges, right? The first one we're in now, which is workforce. If we survive that, right? Then the next thing we get to go up against is the payer provider healthcare industrial complex, right? Where basically you've got kind of, United, Optum, CVS, Aetna, and those kinds of folks, which there's something I really love about what they're doing and something I really hate. What I really love about what they're doing is they're making investments to blur the line and make it a seamless experience between your insurance carrier and your provider, right? That's awesome. If you look at what Kaiser does, they're like a global cap model, contained system, right? What I don't like what they're doing is they're, instead of putting health systems and, traditional players under a global caps or under a risk model, they're negotiating better rates by basically taking, acquiring clinicians within a market and saying, if you don't give me better rates, I'm going here to my own clinicians and I'm going to capture that value that way. That is an economically rational thing for them to do as for-profit companies because it's easier. It's just flat easier. Like I can get, I asked somebody the other day, would you rather try to make, orange juice out of this jug of water and a orchard of oranges, or this thing that's already pre-pulped in a bucket and all you have to do is pour it? That's the literal difference between, managing utilization effectively with health systems or doing what they're doing. So if we make it through that, right? And I think the only way you're going to change that behavior is through some sort of regulation or something like that, because it's the economically rational thing for them to do for the time being. If we make it through that, then you're going to basically face the disruptors, right? And I think while all this is going on, right, we're talking about 5-7 years, you're going to see, and this is going to be awesome to see, you're going to see health system executives see a bunch of disruptors fail and go out of business. And they're going to say, you see, we were right. It's not going to work, right? And what they don't understand is implosions in the financing market, right? Where companies start to go out of business, or, when the bubbles kind of deflate, it puts more capital against the winners and they become incredibly effective. And so the .com bust beget Amazon, right? And it's because it knocked out a bunch of weak kind of e-commerce competitors and all the capital flowed behind a few, right? Like eBay and Amazon, a couple more. And so by the time we get through, the workforce crisis, payer providers, then you've got the disruptors, which will have truly new, novel, innovative models, and there'll be fewer of them, but they'll be more powerful, right? So if you're in the health system, you got some work ahead of you. I guess is my central message.
Absolutely, yeah. One of the things that you mentioned in our prep call was a quote from Jeff Bezos, which is, I wrote it down as, if you disrupt yourself, you have a vote in the future. I'm just curious, maybe any thought around that, around how you might be thinking about disrupting yourselves.
Yeah, I mean, we've done self-disruption effectively in like low acuity, high volume, think urgent care, retail healthcare, and on-demand telehealth. We've done that very effectively, and that was true self-disruption, because we were taking, basically the easy cases out of primary care and putting it into a separate business, right? That's the definition of it. We're kind of competing against ourselves and moving volume from kind of, bucket A to bucket B and starting to segment primary care. where I think, that's what we need to do as health systems. We need to create new businesses that effectively compete against ourselves. At Amazon, we created Kindle. It competed against our physical books business. And there were separate teams with separate technology stacks. And Jeff's whole kind of mentality was go as fast as you can, knowing that some of this will cannibalize our existing business, because if we don't do it, somebody else will, right? And he was more concerned about what we call disruptors than, the big kind of incumbents or whatever kind of coming after him. So I think that's what health systems have to do, is they have to form up separate entities within their organization to compete against their existing business, which is super hard culturally to do. Super hard, because you're basically, if you're in the physical books team, you're like, why not me? Like, I'm in the declining business. Why don't I want to go over to Kindle where it's the growing business, right? Yet you got to maintain your cash flows in the declining business, right? So it's the typical thing that incumbents, none of this is new.
Yeah, that's interesting. Thank you. Any other thoughts? I see one thing I want to call into the room is Barry Peterson. Hey, Barry, makes a really great point in the chat. And I think it echoes some of what Casey was saying, which is that please remember that successful scaling of health technology needs to earn the trust of the patient. And I think that's a really important, especially given the lens through the CTA and DiMe of the focus on the consumer. That's a really important focus that we need to bring into the conversation. And, maybe sort of bring this in to the conversation. Well, maybe Han, I'll turn over to you. And, there are traditional consumer giants, so Amazon, Walmart, Walgreens, that are now starting to play in healthcare. Certainly Samsung is one of those as well. I'm just curious, what role do you see these consumer technology companies starting to play in delivering healthcare, with maybe more of a focus on that consumer experience that you were talking about earlier?
Thanks, Drew. I think that there isn't one clear answer, and I think we're seeing the result of that. So, if I look at Amazon as an example, the way they got into healthcare through prescriptions and their acquisition for PillPack, I think is a story around, they start with their core competency of supply chain. They move discreetly and acquire a company in which they think they can go into. So everyone finds a slice, and everyone's been playing in different areas. Google and Verily, as you can imagine, has played in lots of different areas, really focused around AI and analytics. So what I see is every company is trying to enter into healthcare, recognizing that scale is hard and they can't really just buy up everything. And then the margins are really low, right? It's like 4%. And so a lot of these big techs who are used to getting, big margins and all of this, looks at the market and, the market is not that big, depending on once you get to the addressable market for the specific technology. And once you go down there and then you got the margin issue, all of a sudden there are issues. And so I think that what I'm seeing is that everyone, including Samsung, is looking at what are we good at? Where do we see healthcare opportunities exist? Like for us, who would be in the home, and saying we have existence and presence in the home already. We know consumers, we know how to engage them. And so why don't we create that experience? And then specifically, could we, again, we haven't made the decision, but look at the senior care sector, or aging in place, I think is the term that people have used, although I think people don't like that term. It's more thriving in motion or something else, right? But regardless, I think that you have a huge market of this demographic shift that's occurring. And I think everyone like Alexa and Google and others are trying to hit into that market as well. So I don't think there's one clear answer where I say, oh, all the big techs are taking this approach. I don't see that. Now, one last thing I would say that there is a role to play for one or many big techs is really, do we become a enabler in which we allow some harmonization or unification of the various different digital health investments. So right now, as everyone knows, the fragmentation of digital health is just it's out of control, right? I mean, just there are too many, and for a patient, it's just not meaningful, right? So then the question is, can the big techs play a role in which we begin to enable innovation by building those core component services so that innovators don't have to worry about those core services? And then do we, through data and others, stitch this together in such a way that through a value chain of wellness all the way to diagnostic and remote patient monitoring, as a consumer and patient goes in and out across that chain, are we the enablers of these? And what does that look like? I think that's an opportunity and a challenge, but I don't know that any one big tech right now has really solved that problem. I think there's some notions. I was talking to Gartner the other day about how this might look. In fact, they talked about SaaS and other types of companies playing potentially in the left, and then you have Microsoft and others playing on the right in the healthcare space. So again, I think there's a lot of more unknowns than knowns, but I still see big techs playing to their strength, playing a certain specific sector to solve a problem. And then I think with time, either market will collapse, right? As Aaron said, and we'll start consolidating because of the market force, or you will begin to see consolidation as a natural market force of acquisitions and other investments.
Drew, as we think about how technology became an integral part of healthcare, it really did start with meaningful use and the big push towards electronic health records. That was the federal government stepping in, saying that this is the way it's going to be. We're going to incentivize you and then penalize you if you don't follow these rules. But the one thing that they recognized in retrospect that they hadn't done was to focus on interoperability. And what we then ended up was silos of data, silos of organizations not being able to communicate with each other. It created a major issue, which they are now going back, and as you're well aware, Meaningful Use 3 now becoming focused on interoperability. The good news is that the technology companies that have been moving to try to help address some of these current issues have adopted the standards of open platforms, APIs, FHIR, really trying to find ways that we can move towards more standardized care that goes beyond the encounter. And as we think about where then healthcare and the opportunity lies, it does lie in the home. It lies with the consumer. It lies with all the interactions that we have. So much of healthcare is drop balls, poor transitions, our inability to be able to understand, what needs to be done, who can act and support. That coordination and lack of coordination has resulted in some of the biggest challenges we run into. Now, we have platforms that support across the care continuum, empowering consumers and patients and their caregivers with the right information at the right time to make the right decisions, and then building infrastructure that supports that, we actually have a path forward. So I'm very optimistic about what collectively big tech can do to help address this, because right now the challenge is we have to start unlocking the data, giving consumers access to their information that they own, making it much more interoperable, allowing them to be able to become the control of their own destiny, and then supporting them through processes and technologies that we have today.
Yeah, totally. And, maybe Jen, I'm curious, and Aaron, curious your thoughts on this. So Han and Dave were really thinking about this from an enterprise health, enterprise technology perspective of, how can these organizations help to enable that healthcare layer? And Jen, you brought up earlier more of, I think you said 1 of every 2 Americans goes into a Walmart every day, which is just an amazing stat. And obviously we're using Amazon all of the time, right? And these organizations are actually getting to direct consumer care, to your point. And what's interesting to me about that is you're not getting your MRI at a Walmart, right? At least not today. Like they're very directly picking off the profitable areas of healthcare that they can go at, which probably directly starts to eat into Aaron's margins, right? Because if now, if all of a sudden the easy access profitable things are the easy to do in consumer retail locations, that leaves less profitable services available for health systems. So how are you thinking about that transition? Like, what is that going to mean for the future of care?
One in two Americans walks into a Walmart every week, I believe.
Oh, every week. Okay.
Is my statistic. I don't want to misquote our colleagues. Drew, I'm going to answer your question, but I'm going to start by sort of looping back to Han and David. One of the key things for me, listening to you both speak, is what we believe really deeply about what the digitization of healthcare is at DiMe. It's data. Like, that's what it is. It's better data and it's better information. In the digital era of healthcare, and David, you took us back to meaningful use, data doesn't live in a manila file in a locked filing cabinet in a room that is only accessible to one person at any given time any longer. The whole point of the digitization of healthcare is that we now ostensibly should have flows of really sort of the high velocity, high resolution data from traditional sources and from other sources so that we can make better decisions faster. And I think, Drew, this does loop back around to your point, which is if we are defining the digitization of healthcare as being data driven, that doesn't strip away the human, right? So there is the role for the CVS or for the Walmart, because we still need high touch, whether that's through peer support, whether that's through different members of the care team, right? Let's think about cardiology. By 2030, I think we're looking at a cardiologist shortage of 120,000. That's pre-pandemic data. I can't imagine how bad those numbers look now. So then what are we actually thinking about? If we're thinking about better information that allows us to appropriately triage patients and perhaps people before their patients to the right care, maybe it's peer support, maybe it's nursing care, maybe it's a pharmacist, maybe it's OT or PT. And that's the role for the local touch points, right? Whether that's a Walmart, whether it's an imaging center or whatever it is. And it's all data driven. So long story short, digitization of healthcare, I think, is about data. The humans don't go away, but it allows us to use a quite different team of humans to deliver that personal touch.
Absolutely. Thanks for that. Aaron, anything to add to that? Because I've got a question coming for you.
Yeah, I think I agree with Han and David and Jen. You know, I think if big tech companies are smart, and they are, they're going to sell arms into Afghanistan, not get involved, right? So like, you know, like it is like, you know, like why would you want to employ health system workers why would you want to deliver care, you know, over the fullness of time? It is a, you know, like I always imagine myself pitching to, you know, David's boss or somebody like, hey, I got this great industry. We should totally go all in on it. It's like 2% margins. There's a ton of liability attached to it. And it is the most unscalable services business you can imagine. Are you in? Like he would say no. Like he would, you know, Nadal would say, why would I ever do such an insane thing? You know, like I would much rather, do what they're doing, buy Nuance, you know, really understand the workflows, you know, inside, you know, a health system, buy a strategic asset like Nuance, where like I'm also getting a lot of access to, you know, incredibly robust AI data, and make them that more efficient and hopefully help them kind of straighten themselves out a little bit. I mean, I don't want to speak for Microsoft, but like, you know, you could have that same conversation at Google, at Amazon, at I guess now Oracle or whoever. You know, I don't see them getting. Now, I do think there will be very interesting disruptors who are taking those types of technologies and services and creating and carving up what is now delivered in a big complex system. That is a danger to health systems because we're highly cross-subsidized. There are certain parts of our business that basically fund everything else, right? And allow us to take care of the community. So if we don't defend ourselves from that kind of disruption, we're in not a good place.
Yeah, I think that makes a lot of sense. And Dave, I'm not sure if you have that PTSD or pitching that story or not, but that was.
I don't think Dave is a smart guy. I don't think he ever pitched that.
Oh man. So Aaron, I want to stay with you for a second because one of the questions that came in, I think, really directly related to something you said early on in your introduction, which is that you treat sort of inbound patient inquiries as defects, and I don't think you meant that to say that there's something wrong with what the patient's saying. It's more to say you've not given the patient the tools to understand the healthcare system to navigate this solution on their own, right? And one of the questions was around health literacy and how health literacy can impact consumer adoption of healthcare tools as well as just utilization in healthcare. So I'm just curious, how do you think we can help to amplify healthcare literacy across the spectrum?
Yeah, I think all you need to understand about where we sit with healthcare literacy is go into Epic's MyChart and see how confusing you could possibly make the information we're delivering to patients. So like, I'll give you the example that I always use for myself personally. I'm on a lipid lowering drug called torvastatin. I have to every whatever period of time, David would know, go in for, a blood test to make sure it's not screwing up my liver, right? There's probably one data point I need to see, but because of cures, we show them everything, right? And so if you got other stuff out of range or whatever, it begs the question, right? And I have nothing against showing them everything, but at least explain it to them, right? And say, this is the thing you should care about right here. There's some other things that are out of thing. If you're interested, click in and we'll tell you everything you need to know. And then maybe you stop the email that is reflexive of like, oh my God, there's this thing over here that's like, in the red band or whatever. What does it mean? Am I going to die? Right? Or something like that. That's what creates messages unnecessarily because we give no context around it. I think trying to teach 350 million people how medicine works is like a lost cause. That is an insane attempt. I think what's better is to take medicine and make it consumable by the average person so they can understand what we're saying. And I think there's there's a lot of physicians on this. I'm sure I'm going to get stuff thrown at me. I'm married to a physician. My brother's a physician. So I say this in the best possible light. You kind of want to do that, right? There's this expertise arrogance, I think, that we have in this industry of we like talking in a different language than everybody else. We like to call things in healthcare different things than they otherwise are. So like, for instance, my favorite thing is I'm in marketing, right? What is healthcare called? What is retention marketing called in healthcare? Leakage reduction, right? It's the same thing. Right? It's the same thing. So
what's the payment called? The payment is called a reimbursement.
Exactly. Yeah. So you extend that metaphor to every clinical thing that we talk about. You could make it more easy for people to kind of absorb and say, okay, I'm not going to die. This is not an important thing. I've got the context. Maybe I don't need to send in that email, right?
Yeah, that's a great, I had the exact same experience with a lab report just a couple of months ago, a routine physical, get my labs, and I'm sitting here Googling every single, I have no idea what they are. That makes a ton of sense. Thank you for that. So one of the questions that I'm really interested to hear the group, and I'm not sure who to pose this to, so feel free to jump in, but the question is, who should pay for all of these consumer-facing innovations? Because yes, 100% there are devices and solutions that will benefit people as consumers of healthcare and will help our health be better. And yet it can't all fall to consumers to pay for these technologies. So is this where value-based care comes in? I'm just curious if we could redesign healthcare, what would the payment system look like for these technologies?
Yeah, I'll take a swing at that. But before I do, Aaron, as a physician, I own what you said, and I've never seen an arrogant doctor in my life, but I understand. But to the question, except David, I just want to make it clear, I'm not pointing fingers here. So, I think if you look at the stats of a lot of the digital health companies, the startups, I think the record or some statistic, and I don't remember the exact numbers, but it's around that about 70% or so of digital health companies that start B2C end up being B2B. So what they find out is that they have a great solution, it's amazing, but then they realize that consumers aren't going to pay for it. And so they figure out a B2B2C or B2B as a way to do that. And this is a fairly well-known statistics. And so what this says is that right now in the US, except for the high deductible plan and what's happening there, in the market space, I don't think consumer, culturally speaking, are used to paying for their healthcare. So there's an expectation that this is someone else's problem, and therefore the behavior is driving exactly to that. So while we talk about accountable care organization, I think we had to do that, but I think it missed the patient because it doesn't give any accountability to the patient or the family members, right? And so, you know, I think that's just fairly well known. And so in terms of, you know, where to go with that, I think the high deductibles and self-pay, self-insurance, I think is going to only grow. And so I think it's going to naturally force consumers to pay more for their healthcare, and then they're going to demand more choice, more consumerization is showing up. So I think those forces are slowly moving into the market. And I think that, you know, other capitated systems or integrated systems like Kaiser and others will do their thing. You know, I personally thought when value-based care was going and I was working at 3M, I thought we were going to be at a much different place now. And what I've come to realize is that we are moving like molasses. I mean, it's like so slow. And that this whole value-based movement, other than Medicare Advantage, I want to be clear about that. Medicare Advantage, I can clearly see the movement, and I think that's a success. So right now, I see certain areas in which this is happening, but the self-pay, I don't know that the consumers have spoken until a couple of things change. And right now, I'm not quite seeing that trend moving yet.
Yeah, I agree with Han, except for the part about the arrogant physicians. But seriously, the whole issue is that consumers expect healthcare, and they oftentimes don't know when they need healthcare. And that is the challenge that we run into all the time, because if you expect this to be a consumer-based model, it just doesn't work that way. People don't see any value in healthcare until they actually need it. And then at that point, it's usually too late. And so what we have to do is we have to rethink about how we design these systems and incentivize. If there's no skin in the game, on the other hand, and it's completely paid for by the insurance companies or whoever the third party is, that's not going to work either, because there will be a tendency to overutilize even when it's unnecessary, just because there isn't really an opportunity. So there has to be some incentives built into it that allow for everyone to be working towards the common goals. And I think that we are starting to see that with Medicare Advantage. We're starting to see that where you have other opportunities in value-based care, but we also need to do more than just that. That is really just an example of how it could work, but we have to figure out how to make it work at scale.
Yep. Jen, anything to add?
I mean, just listen to me, right? Clearly, I grew up expecting as a consumer healthcare, but also in a society that expects healthcare. And I think that's the disconnect. Like, honestly, I don't care if a triple bypass is $2 for $1. I don't want one, right? So I do think it's also, I think we are shortchanging patients and the communities to say, if we make it widely available to everyone, people aren't going to take it seriously. I think we only need to look at the last 2 years to say that people care deeply about their health. I think the disconnect that we actually have is consumers expect healthcare. As society, we don't. We don't value healthcare in the US as a right that everyone should have. Every single policy, reimbursement policy looks the same. And I feel, as you can tell, very strongly about this. And I think that, you know, this isn't different just for digital. I was reading some data the other week randomly. The National Eczema Association published some data. 90% of individuals with eczema spend over $1,000 a year out of pocket to top up their care. 8% of them pay over $5,000 a year. I mean, this is not a unique phenomenon to digital innovation. There are patients around the country who are struggling with this. 1 in 4 people with diabetes in the US ration their insulin because they can't afford it. That particular innovation is 100 years old. The system doesn't work. And I think my fear about self-pay and all these sorts of things is, you know, if we start bundling, and I know we've been talking about value-based care for decades and it hasn't arrived properly yet, so I get that, but we'll be more insistent about paying for what works. And if society is paying for it through taxpayer dollars or through more distributed sort of contributions to insurance, then we're going to care about actual outcomes and not just process metrics. And I think that's a change we have to get comfortable with. It's not going to be about a patchwork of point solutions. It's going to be about solutions.
That's a great point. And I think just to tag on to that last point you made, we are paying for it as a society, right? 3+ trillion a year. It's just we're paying for it in a fee-for-service environment as opposed to just enabling it as a right. So I think that's a really good point. And I think that's a great last point to end on. I'm going to ask one last question as a checkout question, rapid fire. So Bill Gates famously said, we overestimate the change that will occur in the next 2 years, and we underestimate the change that will occur in the next 10. So looking ahead 10 years, what new realities will the healthcare industry have underestimated? Dave, why don't we start with you?
Well, certainly there's a lot of talk on artificial intelligence, and so I don't think we're underestimating the true impact on that. I'm going to talk about something that I think that we underestimate the value right now, and that's around CRM. And what I mean by that is the ability for us to be able to leverage a platform that allows for an individual to just pick up the phone and get an answer. That is going to be an equalizer across the board. We love it when people go and use their mobile phone and go to the portals and go to the apps. But for everyone, a lot of people, it's a lot easier to just pick up that phone and call. Now, if the person on the other end doesn't know who they are, doesn't know what to do, you've really underserved them. And what we now have an ability to do is be able to make those systems much more intelligent and essentially become key parts of how we deliver healthcare. And the more that we're able to do that, the more that we can expand care across the care continuum. So I think that that's probably one of the areas that we'll start seeing greater emphasis in the next few years.
Absolutely. Aaron.
Yeah, I would add to what David's saying. I think what he's talking about is the tool that will get to the point that I think what we're really underestimating is patient engagement, the impact of good patient engagement and consumer engagement between episodes of care. It enables better population health if you're in kind of in a risk environment. If you're in fee-for-service, it also enables that as well. So I think that's the big investment that my team is making on behalf of our health system. It's what keeps you kind of, tied to that consumer as your patient. One real quick clarification: doctors are not arrogant; they're needlessly technical. So my wife, in their communications, my wife says that she aspirates her saliva when she's choking. So I'm just going to leave it with that. That's what I'm talking about. She can just say choking, right? And I know what she said.
Totally.
Are you doing this? Is she watching?
I hope not.
Han, what's healthcare gonna look like that's gonna be different in 10 years?
Yeah, I think the wearables as digital biomarkers are going to fundamentally change how we practice medicine. I think it's going to create an agnostic or modularity in healthcare where I think we can piece things together in ways that can't be done. So I say wearables are going to fundamentally change healthcare.
Great. And Jen, bring us home.
I think it's clinician shortages. I think we're really underestimating that, right? We're not going to be able to keep using technology to patch up what we're already doing. We're not going to have the workforce to do it. And I think we need to wise up to that now. We need to think about solutions that empower the clinicians that we're going to have in the system, and think about new members of the care team. We need to think about the fact that great healthcare is clinical care plus more holistic care that comes with it. That, I think, is what we risk underestimating as I look across the landscape today.
That's the word. Thank you so much. I love that point. Thank you everybody for this time, and thank you for the participants for being active in the Q&A and chat channels. And yeah, look, there's a lot more questions. So Renee, maybe we can make this happen again. Thanks everybody.
Absolutely.
Talk to you all soon.
Thanks,
Thanks,
everyone.
everyone.
Bye-bye.
Bye.
Bye.
Everybody.